All right, we'll go ahead and get started. Well, good morning, everybody. My name is Mark Daffer. I'm the president-elect for the Kentucky chapter of HFMA, and welcome to this morning's webinar, Top Tech-Driven Tools Changing the Revenue Cycle Management Game for Hospitals and Health Systems, presented by Meduit. I'll introduce our speakers. Today's presenters are Jeff Neiman and Jason Petrosic. Jeff leads Meduit's top-notch team of healthcare revenue cycle professionals to maximize performance and accelerate growth for hospitals, health systems, and provider groups. Prior to joining the Meduit team, he was the chief operating officer for Navigant Symmetrics, a revenue cycle management company serving over 200 hospitals. He has held leadership positions at Conifer Health Solutions, Humana, and HCA, and has a BA in economics from Bellarmine University in Louisville, where he graduated magna cum laude. Jason drives revenue cycle solutions powered by artificial intelligence that supports healthcare providers' operational, clinical, and financial health. Jason brings over 25 years of revenue cycle management experience in revenue cycle process design, efficiency, and resource optimization. Prior to joining Meduit, he served as National Vice President of Revenue Cycle for Prospect Medical Holdings, Vice President of Operations for Navigant Symmetrics, and Senior Director of Operations Planning for Conifer Health Solutions. He earned his Master's of Business Administration from Pepperdine University. And with that, I'll hand it over to Jeff.
Thanks, Mark. I'm going to start out with just a quick overview for everybody of who Meduit is. In case you're not familiar with the company, this may help just kind of give a little background, obviously, on Jason and I, where we are today, and so forth as we dive into more of the core content after that. So we are a national revenue cycle management company, really I would say a tech-enabled services company. A lot of what we're going to talk about today is technology, but we're huge advocates that you have to pair the technology with service. Oftentimes, it's not just something you can turn on and walk away and expect it to work constantly. So it requires human intervention and action and things like that. And we'll talk about that. But this map here is just a representative sample of where our customers are today with the little green push pins in it. And then on the right are just different locations of our offices today. We've got about a dozen offices around the country, and we're headquartered in Charlotte, North Carolina, which is where Jason and I are dialing in from today. Size and scale of the company, we've got over 1,000 hospitals and physician practices, about 150,000 physicians. Some of those are hospital-based, some of them are independent practices. All the way from small offices to very large offices. We've got about 1,700 employees across those locations that you saw on the previous slide. Again, size and scale wise, we managed about $56 billion in AR last year. So if you think about just the size of the company and the size of our revenue cycle, we're on par with some of the largest health systems in the US. From that perspective. One key difference is that we have a unique approach, we think, to the marketplace, and that despite our size and scale, we're not there to take over the revenue cycle from anybody. Our focus is really on sharing the tools and the capabilities that we have and figuring out where we can leverage, capital investments that we've made and the revenue cycle and make our partner customers better. So as a result of that, we're very focused on service to our customers and very proud of our Net Promoter Score of 68. So while I would ground my kids for bringing home a 68, if you're not familiar with Net Promoter, it actually goes from negative 100 all the way up to positive 100. So anything above 50 is really like an exceptional industry-leading score. I think average in revenue cycle outsourcers is in the single digits. I think the last few surveys I've seen are like a 7 or 8 for the industry. So again, a 68 is on par with names you recognize like Ritz-Carlton, Apple Computer, BMW, really high service organizations, and certainly something that we take a lot of pride in as we continue to build and partner with hospitals and health systems and physician practices to deploy our solutions. All right, so again, just kind of the revenue cycle depicted on the arch there, from scheduling all the way back through kind of denials management and charged off receivables and so forth. The different offshoots you see there in the blue, green, and orange are just different service offerings that we have as a company today. Certainly not intended to be a sales pitch in any way, but just want to share with everybody what we see as some leading capabilities in a couple of high-tech areas that are getting more and more kind of tech-oriented as time goes on here. So today in the webinar, what we're going to cover is just, again, some of those top tech-driven tools that we see changing revenue cycles around the U.S. We're going to specifically here dial into patient engagement solutions, artificial intelligence, and where that's starting to automate the revenue cycle and drive significant change. Compliance with surprise billing requirements, that's something that's popped up and we've seen a lot of people struggle with. And so Jason's going to talk about how AI can really help you solve that without having to make a people investment, if you will. And then, we've got a couple real world case studies sprinkled in here as well, just to kind of give you a so what type of an ROI as we go through some of these. So starting out here, we're just going to open up with a live polling question. So if we can pop up our first question here. What is your organization's current use of tech-driven tools to optimize your revenue cycle? So just choose one of these. You use technology in multiple processes, you use some, have talked about it, but maybe not using a lot, or you've spent really no time using tech-driven tools. So just kind of on a range, with the top being you consider your organization pretty high tech to the bottom one being pretty low tech. Give us a sense of where you're at, and we'll take a look at kind of where today's audience is here. And it's not uncommon. I think what we're going to show you is probably industry leading, pretty advanced technology and capabilities today. So some of these, I'd be surprised if more than 5% of our audience is really deployed and using some of the tools we're going to talk about. But all of you are likely using a few of the tools we're talking about as well, because we're going to talk about simple things like texting patients, and hopefully many of you are doing that. All right, so fairly high tech, and 21% here in the top box using extensively, 53% use some. So 3/4 of the audience here is kind of in the top half of the chart. But again, 21%, really haven't looked at using tech in patient engagement and artificial intelligence. So this is certainly, wherever you are on the scale here, hopefully there's something you can take away from today and learn. All right, next slide. All right, so we're going to talk about a little bit around patient engagement solutions. First of all, I know in operations roles that I've had in the past in the revenue cycle, one of my biggest frustrations were HCAHPS scores. So, many of you are using HCAHPS or some form of that, especially in the current environment where patient experience even counts toward potential Medicare reimbursement. This is super important, right? And I always felt like, right, the patient's getting this survey after the fact. It's typically a week or two after they've actually had the experience and been in the hospital. They may not even have their first bill yet. And there's maybe one question out of several on the list that's related to actual, revenue cycle processes or billing processes. So I was always frustrated with these because I felt like, a patient's grading everything based on their clinical experience or their wait times or things of that nature, much more so than anything that had to do with the revenue cycle. So I've been an advocate, certainly, saying, don't use HCAHPS scores to measure the effectiveness of your revenue cycle. There's so many better ways for you to engage the patient and survey the patient. We'll talk about some of those today, but if your organization is only relying on HCAHPS, I would certainly gladly advocate for you in any setting to say, get away from HCAHPS and use something else that gives you true insight into the patient financial experience. I think HCAHPS are great for the overall experience and the clinical components, just not so great for the financial piece of the experience. So what are some things that are out there that we think everybody should be doing, right? One is pretty simple, although I'm not going to steal Jason's thunder. Jason will talk a little bit about how you can implement artificial intelligence in the pre-service process today and where we see it actively being used. But your first opportunity to interact with the patient really begins before they even step foot in your facility, right? So the leading edge organizations that we see today are heavily focused on scheduling and automating the scheduling process. So whether that's you actually outreaching to the patient with phone calls, texts, whatever, and then even directing them to a website to perhaps self-schedule if you have that capability. That's really kind of where the industry is headed, and probably the most leading technology. Look, we see people still using like legal pads and spreadsheets to schedule patients in certain departments of the hospital. So a lot of opportunity, I think, as an industry for us to get more automated and more just generally focused on using technology with scheduling. Pre-registration, obviously, with denials and things, if your organization, as so many are these days, struggling with just remaining profitable or breaking even, in those cases, really doing a thorough job of pre-registration and pre-authorization makes a huge difference, right? Securing that insurance payment before the patient shows up, or even figuring out the patient's insurance isn't going to pay for this, or it's a high deductible plan that's going to leave them with several $1,000s. How are you going to then reach out to the patient, work with them to secure that? So, what we see as a best practice in the industry is turning the actual check-in process into more like a hotel registration. Right. We see the leaders in the industry taking care of all these things related to the actual date of service prior to the date of service, wherever possible. I know there are emergent and same day type of referrals and things that you can't get to this, but again, best practice we see is that if you had 48 hours or more before the service itself, getting the schedule, obviously you have to schedule in that case, but getting the pre-registration and the pre-authorization, as well as any sort of patient liability expectations set and established with the patient before they even walk in. So that then the walk-in process is simply, if they didn't go online and fill out forms or, use an electronic signature, you're handing them the forms to sign. You're collecting the method of payment, but it's much more of a brief kind of a hotel check-in process, as opposed to come sit here at my desk and spend 30 minutes with me while I walk you through every step of the onboarding and registration process. For patients that aren't insured, it's important to screen up front. We are seeing more and more technology and sophistication around Medicaid eligibility screening. I think a lot of companies come in and do this, as a vendor with inpatient. So if you've got the patient checked in, they're in a bed for a day or two, it's easier to screen them than if they're going into the ER and out. But now what we're seeing with technology is the ability to even screen your treat and discharge patients or radiology services, any of those kind of things for Medicaid through follow-up with texting capabilities. So think about, if you have somebody come into your ER, you don't have someone screening for Medicaid eligibility in your ER, that's okay. You can follow up with all of those patients the very next day with a text to say, hey, we saw you weren't insured, either contact us to give us your insurance information or click on this link to determine if you're eligible for Medicaid. You can send them out to a portal where they can essentially try to self-enroll in Medicaid and or at least answer 8 or 10 quick questions to find out if they might be eligible for Medicaid, and then you can screen through to decide who makes the most sense for you to follow up with to get them eligible. But with disenrollment taking place with the end of the public health emergency, with COVID going on, there are millions of Medicaid patients around the country that are automatically getting disenrolled from Medicaid. And if you're not proactively working or using some sort of tools or process to try to get those folks re-enrolled and re-engaged, you're definitely going to lose reimbursement, see increases in bad debt, and so forth. So again, there's a variety of software platforms out there. There's vendors that use that. We call our combination Med Qualify, which is why the trademark name is there. But really, that's what it is. What I just described is making sure that you're following up with all patients and even outreaching to them, hopefully, if you've been doing that before they were disenrolled from Medicaid in your state. Another item we're seeing, and there's probably around only 1 to 2% adoption rates around this technology right now, but it is some sort of we call it a patient concierge application, or really what it is it's a phone app for your hospital. So again, not to harp on the whole hotel experience too much, but just like if you were going to go into, a Marriott hotel, you can download their app, you can get their key on your key to the room on the app and scan your way into the room now without even stopping at the front desk if you want. We are seeing some leading edge technology around patient experience applications. And I'll say there's 2 or 3 different capabilities with those applications, one of which is geofencing, and I'll circle back to that in a second and how you can use that. But with an app on somebody's phone, assuming they're going to give you permissions to do things, you can do outreach to them before the service and tell them where to park their car. You can give them directions from the parking garage to the place that they're going to have service, right? Walk in this door, take the elevator to the 6th floor, go to the left, right? And reduce some of the confusion, or at least give them a sense of knowing where they're going before they show up. That capability can also extend certainly into the billing process. So one of the things, for example, that our application can do is a patient can take a picture of their bill. So you send them a bill, they can take a picture of it, or there's a QR code on it. They can scan the QR code and get an electronic version of their bill up. They can point to different areas of the bill, and the app will explain to them what they're looking at, right? Those are your itemized charges that you're pointing to. Here's what that means. Here's what an itemized charge is. Here's your, the summary of what you owe. You're pointing now to a contractual adjustment. Here's what a contractual adjustment is. But again, look, hospital and physician billing is complicated. You've got a third party involved many times in payment. It's a confusing, complicated process. And, I even get bills that I don't understand once in a while from people. And so the more that you can do to offer explanations to patients, and as people become more and more digital, I think we have done some webinars in the past where we say about 50% of your patients don't want to engage digitally. So don't go all digital, right? You can't create an app and then get rid of your call center, for example. But I did see a new study out the other day that said in medicine, about 60% of patients are now going digital and prefer digital over more traditional like voice and paper communications. So it is creeping up. We were at 50% probably 18 months ago. And so over time, I think as our population ages out and becomes more and more comfortable with technology, this is going to go higher and higher. And apps, although they only have, maybe 1 to 2% penetration today, they're going to get more and more common. But again, that in our case, at least, our app also offers an opportunity for somebody to text and ask questions about their bill, kind of text/live chat, right? They can text a live person and get an answer back, or they can click on a button and call into the call center directly if they're still confused after looking at their bill. They can link in and make a payment directly, but an app gives you a little more control over the patient experience. And then by downloading that onto their phone, I'm going to jump to geofencing, then I'll go back to PFX tracker. The other thing you can do if they give you permission is you can literally track the person and see where they are. So geofencing, if you're not familiar with it, it's simply like drawing a line on a map somewhere and then tracking when someone crosses that line either in or out. So again, with geofencing, you could track when somebody gets onto the grounds of your campus and text them a message, welcome, thank you, we have automatically checked you in, please go wherever you want them to go, right? Or when they leave, you can text them and ask them to click on a survey about their experience. So instead of waiting a week to send them something from HCAPS, you're getting an instantaneous response from them. And I found it's really quite interesting to see the difference in how a patient responds almost immediately right after service with how they respond a week later down the road after they've had an opportunity to talk with other people and kind of socialize the experience and things like that. You'll see distinct, statistically different results in the response rates from that. Another tool that we're seeing, and again, this is probably less than 1% rollout at this point. We call it the PFX tracker. That's our name for it. Patient Financial Experience Tracker is what that stands for. But really what it is it's like your Amazon package delivery service. So whether you have that loaded on your app or you're texting the patient, you can really do either one. You're informing the patient of what's going on with their bill and the financial process, right? So you can say, you can send them a text that says, we sent the bill to your insurance company today. Click here to see a copy of it, or click here to see a summary of what we sent to your insurance company. We received a denial from your insurance company, right? It's literally tracking every step of the bill process, typically on like a little chart, just like you see with, Domino's Pizza, if you order that, or Amazon, if you're ordering something from them. But again, as people are becoming more and more familiar with that process in non-healthcare aspects of their life, we think it's going to start to make sense for people to want to know what's going on and keep up with it. Again, whether it's app or text, but they can enroll or opt in or opt out of getting those kind of notifications. All right, other items that we're seeing that are high tech and nature, just around self-pay follow-up. I'm going to touch on this briefly. We do like a whole webinar on this and have done it with this group before, so you may have seen it. But again, we are big believers in comprehensive follow-up options for patients. So you have the broad spectrum of people, all the way from, like, I'll say, my parents, for example, who are never going to respond to a text if you try to text them. They check their email like once a week, maybe, right? But if you call them on the phone, they'll answer instantaneously, even if you're a telemarketer and they don't recognize the number, because it's rude in their generation not to answer the phone. All the way to, like, look, my kids that are kind of high school, college age, they are going to want to text with you only. They don't want you to call. If they don't recognize your number, they're going to forward you straight to voicemail. But just in general around follow-up, what I would say is, if you're an organization, and it looks like we may have 21% or so of the audience that falls into this bucket, if you're sending letters and answering inbound phone calls and that's it, you're not offering emailed statements, you're not texting patients when they don't pay a bill, for example, with a link to the bill payment website, if you're not doing those things, you are going to start missing out on communication opportunities with, and I will say it skews younger, right? The younger, the more digital interest there is in communication. But if you're not doing those things, I'll even add online chat to this here. We think it's critical that you start to at least pick one additional avenue or a channel a year for the next couple of years, and roll out past traditional letters and phone calls into these other communication channels. At the end of the day, the important thing is, people have all different kind of preferences, and even, within the different age groups, you've got people that, may not fit the mode that you thought they fit in, right? You're going to have retirees who prefer to text. You're going to have younger people who prefer phone. You're going to see all kinds of those things. In fact, we're seeing, a lot of the younger generation with these high deductible plans, they're really interested in why it costs them what it costs them, and they want to talk to somebody about it, not just text or email at times. So it doesn't always follow kind of traditional buckets, but it's important, again, at the end of the day, that you're offering as many communication channels as possible, because then you're removing the excuses for why patients don't pay their bill, and you're removing the excuses for why patients say that you weren't responsive to them, or you weren't easy to work with or communicate with, or whatever. I mean, again, we live in a world where I can, on my cell phone, reserve an Airbnb, communicate with the owner of the Airbnb, pay for it, right, without ever having spoken to the person I'm staying in a home that they own. So again, we're rapidly getting to, if not already at, a point where even, kind of our very personal healthcare experience is something we're going to want to communicate digitally and electronically with other people. Texting is the area we would probably encourage you to go to next if you're not already there. We're seeing very similar experiences with text that we see with traditional phone calls. So what I mean by that is if you do outreach to somebody who hasn't paid a bill, let's say, you send them a bill and after 45 days, you're trying to make a couple phone calls to them before you send them off to bad debt. We see the same responsiveness rate to text as we do to those outbound telephone calls. So again, we highly encourage you to text. We use some analytics to skew and try to figure out people's preferences based on how they checked in and the information they provided based on age and some of those kind of things. Interestingly, even sex plays a role in that. Women are more likely to communicate digitally than men. You'd think maybe the opposite, but our statistics show show that is the case. So just thinking about how you do outreach to the right person at the right way at the right time with this different technology is becoming more and more important. But at least having the capability for them to choose, for the patient to choose, is critical. And then the last one here is some sort of patient financing, right? So I think what you look at with patient financing is important. I probably 10 years ago was not a proponent of patient financing because I thought it was silly. I thought, hey, you can just set up a payment plan with the patient and take, a year's worth of payments or 2 years worth of payments. And I think you can still do that, certainly. What we've found, though, is that when that relationship is with a bank, the patient takes it much more seriously if it's a bank loan than if it's just an informal monthly payment plan with your facility. So even if it's recourse, if you can find an organization that works with your local banks, brands that are recognizable in your community where folks probably bank anyway, it creates a sense of obligation or even concern that if I don't pay this, it's a local bank name. When I go buy a car or a house in the future, the community is going to know about this medical debt I didn't pay. And so, we're seeing more and more utilization of some sort of patient financing option that, again, gets you paid up front and shifts the burden to the bank. What I would say is, don't sign up with some third party that's going to charge you a 15% fee rate to set up these plans. That's ridiculous. They should be part of your early out collection process. They shouldn't cost you anything extra. The more reputable plans that I see, the bank doesn't even charge anything. Again, if it's recourse, they're not going to charge you. If it's non-recourse, you're going to have some sort of fee associated with it, but don't sign up for a recourse plan at like a 15% fee to your organization. Sign up for something that's free, that the local bank is just going to make money off of interest that they charge the patient, or maybe they're going to ask you to pay the equivalent of the interest and pay 6%, 8%, something like that. That's a very reasonable discount rate. Again, don't get trapped into the 15-20% rates that we see some of the organizations pushing. So just a couple other things, and then we'll get into the AI component. Capabilities that either you should consider again, or maybe talk to your vendor about if you're outsourcing, like your early out process or even your bad debt process. Make sure that you or your vendor are recording phone calls. In this day and age, almost every call center records phone calls. 10 years ago, 20 years ago was really expensive to record phone calls because data was expensive. Today, data is really cheap, data storage and capabilities. And so the cost of this technology has come way down. But you want to be able to go back and understand what's happening on your phone calls. Even more important with that, in this day and age with artificial intelligence, you can monitor 100% of your calls. So I remember back when our methodology was you had a supervisor listen to 10 calls for every employee every month, and they would score those calls and give the feedback to the employee, and they were totally random. Those days are gone. We can actually listen to 100% of the phone calls that every agent in a call center takes, and we can automatically score them based on voice analytics. So there is voice-capable artificial intelligence that can figure all that out today. It can listen to calls for inappropriate language that's used by an agent and automatically alert their supervisor in real time if something's happening. If there are certain words or phrases you don't want said, it can alert you. All those kind of capabilities exist today. through voice analytics. So really cool technology, and allows you to QA 100% of the work that's taking place. And then we've taken that a step further with something we call Med PFX scoring. So again, it's just the patient financial experience scoring, and what that does is it benchmarks how your patients are reacting versus others. So it listens for tone of voice, it listens for catchphrases and keywords and things. And you may say, so what? What I would tell you is, like, we had an example where there were two very large regional similar sized health systems, and one of them was getting significantly higher patient satisfaction scores than the other. And the organization that wasn't getting patient high satisfaction scores said, can you guys analyze our calls and help us figure out why? And sure enough, what we found out was, very quickly, in about a week worth of going back and doing the analytics, they had a patient estimation tool that was not accurately estimating what the patient responsibility was. Patients were overpaying, finding out on the back end that they overpaid and wanting a refund, and they were understaffed in their business office and weren't staffing to give patients refunds quickly, and it was taking 30 to 60 days for them to issue a refund check to a patient. So in a very short amount of time, we were able to use this AI to inform that particular health system, hey, this is your problem. Go change out your patient estimation technology, staff up your business office to get those patient refunds issued sooner. And between those two, you're going to fix the problem and get better patient satisfaction. And that's indeed what happened. All right, I'm going to wrap up here with a quick case study, and then turn over to Jason to talk about AI. So this is just, we worked with a 5-hospital nonprofit health system. They were really pretty basic in their patient engagement. They were the group I talked about earlier. They're sending paper statements, they were answering inbound phone calls, and that was all that they were doing. And so, we came in and deployed most of what I just talked about. They still don't have application on the phone, so they aren't using that concierge application, but all the other things. So we implemented multiple communication channels. We stood up a web portal, started doing texting, web chat, deployed pre-service solutions, all those kind of things. At the end of the day, just to give you a sense here, the net result, again, 5-hospital system. Jason, if you'll switch to the next slide. They increased their patient collections about $500,000 a month, or $6 million a year. So almost $1 million a year extra to the bottom line of those facilities. We could probably get into an in-depth argument about whether that's cash acceleration or true pickup that hits the bottom line EBITDA, for example. But either way, even if you took $6 million and reduced the collection fees on that 10%, because you're collecting it up front now and not in bad debt and paying an agency to collect it, right? That's a still mid-6-figure ROI on that. So either way you look at that, again, I think it clearly creates a mandate for maximizing your communication channels with the patient. The more informed they are, the fewer objections they have, the less confusion they have, the more likely you're going to get paid, and paid quickly. So I'll wrap up with that piece of it. Happy to take questions at the end, and turn it over to Jason to talk about AI tools and the deployment of those in the revenue cycle.
Thanks, Jeff. All right. So, what I want to share today is just, our kind of vision of this. You heard that Jeff and I both have kind of extensive experience in this industry. So we've kind of seen all of the challenges over the years that we've come up with. And so, Jeff talked a lot about great tools and technologies that you can kind of plug in either directly into your rev cycle operations or through your vendors in dealing with patients, things like that. Those are all things that you absolutely should do. But when you think about, some of the other processes within the revenue cycle, the challenge that the industry has faced for many, many years. I mean, way before COVID ever kind of disrupted things, there's always been a challenge with staffing, right? You have too much work to do to get it done, and you have to prioritize that work, right? You don't have enough employees to do everything. And there's obviously a constant push and pull with, the finance leadership in your health system saying, hey, you need to get the AR days down and you need to bring in more cash. And as rev cycle leaders, we say, great, we need more staff to do that. There's always that challenge there of trying to get enough people to actually meet the goals and expectations of that finance leadership. So, one of the big trends now is using, autonomous labor, robotic process automation, AI. There's all sorts of different labels for it that you can think in order to help capture some of those tasks. And again, this is the idea here is to gradually lessen the burden or the need for human people sitting in chairs doing the work every day, whether that chair's in home now because of COVID, everybody's working remotely, or in an office, or in a registration department in a hospital, wherever that is. We're looking for all of those opportunities to reduce that staff need. So from a Meduit perspective, we actually have some tools that we offer in this. As I would say, if you're out looking for opportunities in the industry, I'll try to kind of tie this back with not just kind of the things that we do, but really the things that you should be asking any vendor for throughout the idea of capturing these automations. So here's a summary slide, and I do not have time to read through all of these, but just to kind of give you a flavor of where we can go, and I have a few follow-up slides to this that I'll get into a couple of these in more detail. But just kind of starting up front, Jeff alluded to this a little bit, patient access. One of the challenges from a staffing perspective for every health system is dealing with authorization requests, right? And so many services that your physicians, whether they're owned and managed by your health system, or your community physicians, or referring patients to your organization for services, a lot of things require authorization. That's just kind of the nature of the industry. And unfortunately, the industry has not adopted a universal EDI transaction for submitting an auth and checking the status and getting the answer back and all that kind of stuff. So that falls back to people. There are lots of technologies that can help accelerate this, but at the end of the day, getting the status for all of your pending auths every day to see if any have been approved or if any have been denied or sent to peer-to-peer, it's time consuming, right? You have to check every single one every day. And so you think about an employee that has to do that type of work. You give them a queue of 100 patients with scheduled appointments and auths pending, and they're going to go and check on the payer portals and log into each one and track it down and figure out, okay, still pending. All right, move to the next one. Okay, still pending, move to the next one. That's a burnout job, right? You think about the employee engagement and employee satisfaction of people working in your health system. Anything that you create that, or the system has created, that is busy work and grunge work, is going to burn people out, right? Those people are going to turn over. They're going to look for other jobs. In today's market, they can go working fast food probably for the same amount of money as they make working in patient access, unfortunately. So you actually have to think about, how do I keep people engaged, right? People are hard to find and retain, but once I've got somebody, I really want to give them the best opportunity to be successful and feel like they're contributing to the organization. So having an employee that goes out and checks something to say, hey, it's still pending, hey, it's still pending, they don't really feel that satisfaction they've contributed to the process. So that's just one kind of example. There's a lot of different things, prior to the patient's visit, that you could use, automation to kind of capture these repetitive tasks for. Verifying eligibility. Everybody's got real-time eligibility systems. Awesome, it's great, but people still kind of bypass the warnings on those sometimes, right? And so you get things that go through and they either get stuck in billing or stuck in denials later downstream because somebody didn't check that warning that came back through a eligibility message and address that issue at the time, right? And so you can create automation that goes and looks at all of those warnings, right? And fixes all of those things kind of on the fly. Anything where you've got data entry moving back and forth, If you've got multiple different systems, maybe you've got a different system for your physicians than for your hospital, and somebody actually has to take the registration information out of the physician system and add it into the hospital system in order to register a patient for an MRI or something. Those are the kind of tasks that are great opportunity to look at for automation. So a lot of stuff in patient access, mid-cycle claims editing, release of information, requests that come in for other health, physicians are requesting a copy of a X-ray or something that was done at the hospital, going through all of that logic to verify that the request is valid, complete that request and get that sent back. A lot of repetitive work in that sense. When we think about kind of the AR, post-billing timeline, there's a ton of work that has to be done to kind of keep your AR down, keep your AR days down, whether that's something that directly generates cash, like correcting a claim that was denied with a correction. That could be something like correcting a modifier to get a claim paid, whatever that situation is that you've got with your payers, so that you see the same thing over and over again that comes back in an unclean claim, right? It's a claim that doesn't go through and get automatically paid. It requires people today, right? And so you can look at what are those repetitive things. Ideally, you want to solve those in advance, but in reality, they're still going to kind of come through and you're going to have to deal with those. So whether it's something that's going to directly generate cash, like something like a corrective claim, or uploading medical records to a payer, which is another big one that we see, there's a lot of opportunity there, or it could just be AR reduction. Depending on what system you're on, each system has its quirks, Epic, Cerner, Meditech, wherever you're on. Some do some things better, some things have some gaps. But you think about like secondary contractual adjustments, things like that, where the system may not automatically take care of it for you. You have to have an employee sit there and go through those and do that. That's something that's not a high priority for the business office, right? You're trying to look at high dollar claims, you're trying to get cash in the door. Keeping that AR clean is one of those things that tends to fall down the priority list, and again, based on resources, you may not have enough people to do that. So each of these things in the lists here that you see are tasks, right? If you think about how to apply AI, labor, virtual labor, robotic process automation, don't try to think like, oh, I'm going to completely transform the rev cycle and all my employees are going to go away and go on vacation. The reality is that our business is so complex that you have to think about it kind of process by process. Think about it, from a rank order the opportunities, right? You look at things where you've got work queues that are backed up, or you've got a bubble of AR, or you've got multiple people doing the same job because you need 4 people to get this particular job done. Those are the opportunities where you look at from a priority perspective, like, okay, what can I do with that process, right? And so, my recommendation to everybody is don't try to boil the ocean, right? You're not going to solve everything overnight. Pick one process that is consuming a lot of labor in your organization and tackle it. And then you go to the next one, and you go to the next one. And through iteration, you can actually make some pretty transformative change, right? And so I think, AI and robotic process automation is still relatively young in the rev cycle industry. We've been doing it for a couple of years. I know organizations have tried, some have stopped and started and stopped because it didn't really give them the value they were looking for. And others are just kind of getting into it now. So I think, 10 years from now, you will see an extensive amount of task automation in revenue cycle. So as you're thinking about what are those opportunities, I'm sure some of these things might resonate with you as potential, but definitely think that, you can find something that will work. And just to, kind of show you what that looks like, it's working accounts, right? You have, virtual employees essentially working in your system, just like human employees and can kind of look over their shoulder like we have here in this quick little video that we're showing you, and monitor what those employees do, what those virtual employees are doing, making sure that it's doing everything correctly. If you need to do QA on something in the middle of it happening, you can do that. But that's just kind of give you a feel for, what is the goal, right? When you actually have this up and running, what is the value? Okay, well, here we've got, 20 employees or however many that is to, be working without having to pay those employees, salary and benefits. So that's the ultimate value, and that's kind of the goal of applying all of these technologies. So just to kind of dip in a little bit more to some of these and spend a few minutes on this, and I'll check our time here. We've got about 10 minutes left in the hour. So I'll go through and kind of pick a couple of these that I think are interesting. So we talked a little bit about, patient access and all, these repetitive tasks. I think, one of the, things that I see in a lot of our clients is still a challenge around employees in registration selecting the right plan code based on the information available to them. If you're in a managed Medicaid, state, I'm not sure if Kentucky is off the top of my head, but if you have managed Medicare, a patient may show up with Medicare, with their Medicare card. You can run Medicare eligibility through the system. Medicare comes back and says they're eligible, and then down in the notes it says, oh, they have a replacement coverage with Humana. And unless somebody is actually going through the details of that, pulling that out, they're going to potentially allow that patient to be registered as Medicare when they really should have been registered as Humana managed Medicare. And so we see that a lot, right? We see that, and I'm a proponent of use all of your tools and technology in collaboration, right? And so absolutely, if you have the opportunity to fine tune your eligibility system to prevent the person from doing that, great. Not everybody has the ability to quickly change how their patient accounting systems rules are set up. And so, you may put in a request IT and it may sit out there for a couple of months before somebody can actually make a change. And in that interim, claims are leaking through with that, potentially with the wrong coverage in it. So it could be, managed government is one. The other is just, simply like payers that have multiple plan codes in your system. Blue Cross is a good example. You usually see clients that have 5, 10, 20 different Blue Cross plans listed in their patient accounting system. And running eligibility may not clearly indicate in the eligibility data which plan of those 20 should be picked. And so employees pick the first one on the list, or they pick the one they think it is, and might not always be exactly the right one. And it's important because that data might, cause the claim to go to the wrong place, but it also might go to the right place, even if it's kind of a mismatch. They picked PPO, but it's an HMO plan. But then you actually have expected reimbursement issues, things that flow down through the revenue cycle. So the ramifications of not picking the right plan code go beyond just getting the claim out the door, right? It could be, financial things that have to be cleaned up, or, reclassed, a patient from PPO to HMO if that affects your contract and your financials, things like that. So I think, coverage validation is very important. I think it's kind of underrated in the opportunity that it provides back to RevCycle. Again, the idea is going to be cleaner claims, fewer denials, less work downstream. Yes, it's more work up front, and the reason it doesn't always happen is because of staffing challenges. So again, if you can supplement your existing people in patient access with tools like robotic process automation that can do some of that work, you can really get that payoff by having that cleaner claim that goes out the door. Moving to kind of the mid-cycle, claim edits, I think, is one of those things that has actually kind of surprised me, right? I've been doing RevCycle for 25 years, and we've been doing this automation for a couple of years. But I think there's a lot of hidden cost or hidden employee time spent on scrubbing claims. So I'm a proponent of build every possible rule you can in your claims editor to stop a claim that potentially needs to be stopped and review it, because I think you should have a perfectly clean claim when it goes out the door so that it pays with no further work that's required. Not quite the reality, that's a little bit of a utopian view, but I still think that you should, engage in building as many edits as possible. Now, some health systems have done that, that's awesome, but that creates that work for somebody at the point of claims editing, whether you call that person a biller or you call it some other role, to scrub that claim to make sure that that edit is reviewed and either an adjustment is made to the claim or the edit is released as not being anything that should stop the claim. So things like, if you've got pro fee claims where the place of service is in the hospital, you may want to stop those pro fee claims to make sure there's an auth on it, right? Maybe the hospital side got the auth when the patient was admitted or scheduled for their service, and maybe that didn't cross over through the systems and automatically apply to the pro fee claim related to that hospital visit. But if there's an auth out there, you want to absolutely grab that, put it on the pro fee claim to make sure that it's present when that claim goes through for submission. So great example of some reason where you want to proactively stop a claim at billing, but creates the labor for somebody to go through and check that. So auths is one thing. Looking at modifiers, certain payers might require modifiers that are generally optional or secondary to the whole industry. That might be things like a right left modifier. Some payer might want that, say you have to send me the right left on a radiology claim, and other payers don't require that, right? So there's some that conditional modifier logic and things where you've got a biller type employee that's looking through and editing, the additional data on the claim. So lots of different examples on that, but I think, that tends to hide a lot of labor. Some organizations, don't necessarily have dedicated people to billers, right? They have, the AR team and, for the first couple hours of the morning, if I work Medicaid, I got to go in and look at the Medicaid claims and make sure they're scrubbed and out the door. And then in the afternoon, I'm going to follow up on outstanding Medicaid claims, right? So it's kind of a mixed job type in some organizations. And that's why I think this might be a little bit of a hidden cost, right? That is an opportunity for you to look at automation and freeing that up. Because if you can take the biller who spent 2 or 3 hours scrubbing claims in the morning and cut that down to 30 minutes, right? Because you've taken the high volume repetitive stuff off their plate. You've left a few things that you want them just to look at, but then they have 2 hours more of their day to do follow-up or write appeals or try to get claims paid, things like that. So the whole idea with all of this is look for the areas where you can reallocate your labor in the organization. So I know we're kind of running through the time, so I'm going to zip through a couple slides here and come back to our case studies. And just say, the goal here is focus your staff on the things that are going to add value in the organization. So we've done this over a number of organizations. There is a material value for this here. And, the example on case study 1 has to do with an organization that had more volume of claims than they could ever touch. And so they have a lot of small dollar claims that got deprioritized, right? People are obviously going to focus on the high dollar, inpatient stuff. Absolutely, that's what they needed to do. But you've got a $250 radiology claim that just needed a quick edit and reprocess the claim, and it would have paid. But people don't get to that, right? And so your AR ages out because you don't have enough time to get to those. Potentially you've got those roll over to a vendor at 90 days or 360 days where you say, okay, I never collected this, maybe somebody can do something with it. But if you can look at those things that are happening repetitively, and that's what we did in this case studies, we actually found several things that just were quick corrections, but it was happening so much that people couldn't get to them timely. And that's how we were able to accelerate $500,000 for this organization. Our second case study, was really kind of looking at those volumes of throughput in any particular process, and looking at undistributed transactions, claims per month, authorizations per day, anywhere where you see a ton of volume go through there. And then just to kind of close with surprise billing. I know we talked about this. this is a thorn in the side for every health system. You have to send a letter to anybody who's gonna, owe a bill, essentially. If you've got the tools that can do your patient estimation, but you still require somebody to go through and generate the letter, send it to the, mail it or send it to the patient, you can use the AI automation, again, just looking at those repetitive tasks to generate that and push it out, right? Generate it and push it out. And again, this is one of the tools that you can use to help kind of relieve the burden of that process. So just to kind of bring us back, I think, there's a ton of tools, both from, the patient experience side that Jeff talked about, the AI side that I talked about. There's lots and lots of things out there that can help you. My takeaway as we wrap up here is don't try to solve everything with once. Just, take a bite at the apple, right? Take a little bit, one step at a time, and gradually, bring all of these tools into play, whatever is going to be the most meaningful for you, for the organization.
Thank you so much for presenting, and we hope that everyone has a nice rest of their day.
Thanks, everyone. Thanks, Aaron.
Thank you.
Bye.